6, and it is 4:06 p.m. And as a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members, do we have anyone online? Is he going to join? Okay, if Manager Motwani joins, if you can let me know, that would be perfect. Thank you. So, committee members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. At this moment, we are going to take public communication. I would like to announce that in order to make it more accessible, we're only having one meeting this evening, correct?
No, two.
We're having two.
Executive committee.
Yeah, board of managers.
Oh, board of managers.
Okay, see, I'm behind, sorry. So we are gonna make, I know usually we have a standing meeting for community members at 5:30 p.m., but if there's anyone in the community would like to talk at this moment, we would be happy to take them at this moment in time, if it pertains to the Budget and Finance Committee. So, Yasina, do we have anyone that would want to talk at this time?
Cynthia.
Oh,
Hello.
or,
Hello, yes, we do.
yes, please, Mr. Jones. So, yes, could someone read him?
Yes, there's Sarah Hayes online that will read
Yes.
the
So,
Okay.
yeah, so we
Go
do
ahead,
have someone
Mr.
that
Jones.
that is online.
We can't hear you.
We do have someone online to speak who can go after Mr. Jones.
Okay, do you want to read out the
Yes, yes, I will.
the
Thank
verbiage?
you.
Okay, beforehand, so I know with our previous manager, Shannon Jones, he knows it in and out, but for those who are online,
Yes.
okay, thank
So
you.
Central Health Board of Managers public communication guidelines are as follows. Please introduce yourself by name before beginning your comments. If your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. Once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. Please proceed, Mr. Jones.
Thank you. Welcome. Do you have it on? Yeah.
Good afternoon. Thank you for the opportunity to come and speak to you. It's good to see my old colleagues. It's been quite a while, and wish you the best of luck as you continue this very difficult challenge. I'm here to speak on behalf of two organizations that I feel, as you go through the budget process, should be supported. I know the challenges that you face, and I know the challenges that our community face, but I want to, as a former board member, as a community person, want to speak on their behalf. And I know I have 3 minutes, so I'm going to go through this rather quickly. I'm speaking on support of two agencies. The first one being that of the Black Men's Health Clinic. That is a model clinic that has taken on national attention. It has, in concert with community care, been a role model for how we reach populations of color, particularly men of color. And given the data that we currently see, and given what we're seeing nationally, that more than anything else is necessary for us to do. So I encourage you, as you go through your deliberations of how you're going to fund organizations, which organizations you're going to fund, that you keep in mind what the ultimate goal here. These are taxpayers' dollars going to fund those who are indigent, and that is the same with the Black Men's Health Clinic. It has national attention. It's been viewed on the national media and as well as others. So I want you to recognize you have a jewel here, and it's an organization that can carry you from where you need to be. That is getting into the community, talking to people, helping them to understand what it is to get health care, and making sure that they know the system and utilize the system to its max. The second organization I'd like to speak on is that of C2H. That organization has been around for a while, and we've been consulting with them, or the board consulted with them in terms of reaching targeted areas within the community, particularly communities of color, African Americans and others, making sure that not those who have access to the website or those who have access to the television or those who have access to others know what we offer. They're out in the streets, in the apartment complexes, on the corners, doing those kinds of things. In this period of time where the environment is very toxic and very difficult, it is important that you, as leaders in this community, continue to support that, because your success or the community's success will depend on your making sure that those focus areas are continued, that you don't give up simply because other people don't want it. Now, I cannot see how much time I have left, so will I get a zing? I'll get a zing, okay.
Yes, we have 30 seconds left.
30 seconds, okay, thanks very much. In my many years here, well, with 8 years here and 17 with the city, one of the things I was the most proud of is that Austin is a leader in terms of addressing its indigent population. And you, as members of the board, are representative of that leadership. But leadership doesn't come simply by sitting around the table and desk and voting on things. It's getting engaged, paying dollars, getting money in the targeted areas. So I encourage you, as you go forth in your budget deliberation, to consider these two organizations. They have made a national attention, and they will continue to represent you well. And thanks very much, and it's good seeing you all.
Thank you. Mr. Jones, that second organization, can you send us that information? I'm not familiar with that
C2A,
organization.
okay, all right.
That would be helpful, thank you. And
Next.
the next speaker?
Yes, we would like to introduce Ryan Pope to speak next.
Good afternoon, Chair Rodriguez and members of the board. My name is Ryan Poppe. I represent the United Workers of Integral Care. I'm here today on behalf of the dedicated behavioral health professionals who serve Travis County residents every day. Thank you for your continued partnership with Integral Care and your commitment to expanding access to health care in our community. As you consider the budget, I ask that you continue investing in behavioral health services that thousands of our neighbors rely on each year. Every day, Integral Care's workforce provides crisis intervention, mental health treatment, substance use services, housing support, and care for individuals with intellectual and developmental disabilities. Our teams help people receive treatment before a crisis becomes an emergency. Those services don't just improve lives, they strengthen our entire healthcare system. When people receive timely behavioral health care, they are less likely to end up in emergency rooms, require hospitalizations, or become involved with law enforcement. That leads to better outcomes for patients and more efficient use of public resources. Central Health's partnership with Integral Care also helps maximize the impact of local investments by leveraging additional state and Medicaid dollars. Maintaining that partnership allows Travis County to bring more healthcare dollars into our community and serve more people in need. As demand for behavioral health services continues to grow, so does the need for a stable, well-supported workforce. The professionals I represent are committed to serving the community, often under challenging circumstances. They deserve the resources necessary to continue providing high-quality care to those who need it most. On behalf of the United Workers of Integral Care, I respectfully ask that you continue prioritizing your partnership with Integral Care and the frontline professionals who provide these critical services every day. Thank you for your time, your leadership, and your commitment to the health of Travis County.
Thank you. does that conclude public communication? We have one more?
We have one more speaker.
Okay, please move forward.
To introduce Isela Guerra.
Good afternoon, Board. My name is Isela Guerra. I'm Senior Manager of Community Engagement and Outreach at Central Health, and I'm here to share an update about Vivir con Ganas Community Health Expo. This is the Spanish Language Health Expo for our patient population in Travis County. First, I will just say that you will find a memo in your board packet with some logistical details, and I just wanted to make sure you were aware that that memo was in there. I want to use this time to share some exciting updates that were not included in the memo because they just were not finalized yet. We do have a exciting lineup of speakers that our attendees will recognize and enjoy this year. We sought local leaders in health and wellness to deliver our content in a personable and engaging way. We have Danitza Verdugo, a certified Zumba instructor with over 14 years of experience and a Central Health partner for nearly a decade. She's been offering free classes at our health and wellness centers, and those classes are always full. We also have Ruben Pizarro. He is a current community health worker instructor and a healthcare navigator at Caritas, as well as a radio personality on the UT Longhorn Spanish Radio Network. He has experience in sports medicine and Spanish medical interpretation and translation. We also have this year Margarita Foss. She is a certified emotional wellness coach based in Austin, and she holds certifications in life coaching, neuro-linguistic programming, and emotional management. She's also an author and a host of the podcast, The Empowered Latina, and will be providing content and presentation at our event. And then finally, our keynote speaker is Liliana Beberido. She is an author, a counselor in training, a mindfulness instructor and life coach, and community advocate passionate about helping people reconnect with themselves and live with greater intention and purpose. All of our speakers are native Spanish speakers. They're engaging. They have great following within the community and our patient population, and we're very excited to partner with them at this year's Vivir con Ganas. You will start to see our paid media advertisements. Those go live Monday, August 3rd. Promoting the event this year, and our grassroots outreach to partners and other organizations has already started. So we're very excited about the event. It is Saturday, September 12th from 10 to 4 at the Hyatt Regency Austin.
Thank you.
Thank you.
I'm gonna follow up with you guys offline to some of the services that perhaps we should also include to expand some kind of screening on, because it was very well attended last year. So we can discuss this offline. I know it's not posted on our agenda. Thank you.
Thank you.
Does that conclude our public communication?
Yes.
Thank you. Okay, with that, we are going to proceed to our agenda. Agenda item number 1, approve the minutes of the June 24, 2026 Budget and Finance Committee meeting. I move that the committee approve the minutes of the June 24, 2026 Budget and Finance Committee meeting. Do I have a second? Dr. Brinson, second. Any discussions? I see none. All in favor? Motion passes. Thank you. We are moving on to agenda item 2, receive and discuss a presentation on the proposed fiscal year 2027 budget for community care health centers. Dr. Yagoda and Joy Sloan will be presenting. Managers, this is the first time that we will be hearing from community care about their upcoming budget. I am gonna allow them to present, and once they conclude, we'll take questions because, yeah, so let's do that, and welcome, and let's move forward.
Great, thank you so much,
Thank
Chair Musaitif of the Finance Committee and Chair Rodriguez of the Board of Managers, to the rest of the Board of Managers. It's great to see you all again. Thank you for welcoming us. I want to give a particular thanks to Joy Sloan, our CFO, and to Tara Trower, our Deputy CEO and CSO, who were instrumental in leading the development of this budget, and we're delighted to share it with you tonight. So to start, we present this as a strategic investment plan to expand access, improve outcomes, strengthen our stewardship, and support long-term sustainability of community care, the foundation of this evolving health system. If we could go to the next slide. This shifts from a year in which we have been preserving performance to one where we are explicitly investing in targeted growth. What we need this year is targeted investment in workforce, in access, population health and analytics, care gap closure, enablement, and scalable infrastructure. What this ultimately supports is system value, again, strengthening this foundation for an evolving system. This is not simply a founding request. It's a growth plan that balances mission impact, financial risk, and sustainability. If we could go to the next slide. So these are the headwinds that we face in developing this. We are managing unavoidable cost growth, but we are also funding targeted capabilities to help us navigate that seamlessly. Some of the cost and margin pressures we experience will not be unfamiliar to you all. Inflation and contract renewals, market and merit wage adjustments, fluctuating Medicaid enrollment, provider recruitment gaps, and a known pharmacy margin deficit that we expect at minimum to be $2 million projected for next year. The strategic question we've been asking ourselves all spring has been, where will investment have the greatest strategic impact for us? And we answer this in this preliminary budget by prioritizing access, revenue performance, infrastructure, and lab services. So again, focusing on that vision to really fortify the foundation for this evolving system. Next slide, please. The core growth drivers for this next year will be exhibited as an output in encounters, but this plan is really driven by capacity expansion, staffing alignment, a better throughput, and full year execution of work that were previous year investments. So the four key drivers are expanding our dental capacity, growing primary care also at Hancock, improving provider throughput, and this is really about efficiencies in our day-to-day workflow, optimizing our care model to allow ease of access at higher throughput, and then capturing the full year impact of the investments made in this prior year. Combining capacity, staffing alignment, throughput, and that full year execution, we believe, leads to a really sustainable growth in our access. Next slide, please. On the provider recruitment front, we know this has been the subject of not only our own interest, but this board's particular interest as well. We want to share a number of the stabilizing efforts we're underway, particularly for high-risk services, while we'll also be converting recruitment momentum into real clinical capacity. So the first area is targeted turnover drivers. That is primarily amongst our advanced practice provider group, primary care, and certain specialty segments. Early signals have really shown an elevated first-year APP turnover, so that we are not equipping our APPs to sustain the initial work that they're experiencing when they first come onto the field. That's a real growth opportunity for us. Second, stabilizing really high-risk, high-value services for us. That includes adult primary care and women's health in particular. There have been explicit shortages there that have created operational risk that we're going to double down on to ensure continuity and expanded services. Next, our advanced data-driven retention efforts. These will map the life cycle of our staff, validate findings that we have subjectively already determined, and align turnover metrics with thresholds that we set at the senior level. And then we'll be onboarding new provider capacity. We expect in the next 2 to 3 months to onboard approximately 20 separate providers. This is a testament to the incredible work by our clinical services and our people departments who have collaborated in new ways to onboard an expanded workforce. So again, this new retention insight, recruitment momentum, onboarding executions, we hope will be able to generate sustainable provider capacity that will endure and help secure our position. The next slide looks at the strategic investment. So towards the end of this, we'll go over what is the maintenance of effort work that we'll be doing to ensure we maintain and optimize the level of performance we have. These are new investments for us, above and beyond what we already do. The net is $1 million investment. And we should be able to onboard nearly 44 additional FTEs in 4 key priority areas. The reason it is only $1 million investment is because each of these investments we expect to generate revenue on their own, so the net is $1 million. The first is expanding access to care. We're doing so while preparing for a more value-oriented structure. We're focusing on care management, dental, women's health, and an oral equity project, which is the integration of dental services within primary care for ease of access. It will cost, we expect, $2.66 million and generate $2.3 million and include nearly 21 FTE. The next priority area is revenue and pharmacy optimization. This includes expanding targeted pharmacy leadership, informatics, and 340B resources, which should cost $730,000 and generate likely $1 million with 3.6 FTE. Operational infrastructure to help make a more efficient, higher streamlined, and effective workflows will include expansion of revenue cycle, business intelligence, expanded registration, care model, and nursing teams, with a $1.8 million investment expected through efficiencies to generate an additional $1 million in revenue. And lastly, a rather large project that we'll dip our toe in this year with a small investment of $150,000 for key planning personnel as we start to build up in-house central laboratory capabilities. So in total, it is a $5.3 million investment with an expected $4.3 million return, netting us a total investment of $1.0 million with a 44 FTE increase. Next slide, please. And this is the summary. Starting from left to right, last year we would be continuing the investment. We're asking to continue the investment that Central Health gave us at $98.8 million, with a additional $9.8 million that is a maintenance of effort amount. And this is what pays for merit increases, market adjustments in salary, inflation to the cost of goods, and additionally, the cost associated with an expanded team now being carried over the course of the full year instead of just the partial year on which they may have been onboarded. So that is continuing to maintain the services that we are currently offering. I mentioned the $1 million additional strategic initiative for new services. And then through collaboration with Central Health, we want to recognize the cost of support services for community care, which Central Health has generously covered for the past couple of years. And so this represents really just a net budget transfer from Central Health's books onto Community Care's book. Is not new activity. It's continuing the present activity we have. So in total, that comes to $117.5 million. That will represent about 40% of the total budget at Community Care. And through this out of this, we should get enhanced revenue with optimized efficiency that should help Community Care drive Central Health strategic investments, be able to drive the fiscal year 27 objectives and key results that we have collectively agreed upon, and move us forward to a more advanced and sophisticated future. So the last slide is just, again, a summary. The closing ask is to understand that this FY27 preliminary budget request is to fund very specific targeted growth. We feel we've been able to be disciplined in this investment, asking for just new services of only a net of $1 million, while optimizing the internal continuation of the present services we have. Thank you for your time, and we would welcome any questions you may all have.
Thank you. I'm going to start a few
Please.
questions, then I'll open it. first of all, could you walk us through the process, how you came with this budget? Was this in collaboration with Central Health? Did you, like, in terms of, if you can just walk us out really briefly, the process, how you came across that number?
Yeah, so we started this process in January, where we started the initial creation of the fiscal year 27 objectives and key results that we felt would best serve the system at large, brought those together with Central Health leadership, Sendero leadership, which materialized into the objectives and key results that were approved for this coming fiscal year. As soon as that, and somewhat in parallel to that, we started to develop initial asks of our teams to understand what were the core drivers that they felt were needed in order to achieve these objectives for this coming year. And we received nearly 90 different requests from our teams. And over the subsequent months, we spent a good deal of time trying to sift through what were the ones that were going to have the highest impact and aligned best with our partners at Central Health and Sendero in order to deliver the outcomes that we had collectively aligned. And then through a series of back and forth development that Joy has led with Jeff, trying to figure out how best to position all of these funding investments together, in particular around the shared overhead allocation. There was a lot of attention to ensuring that this advanced the mission of creating greater transparency from a regulatory standpoint and securing both Central Health and Community Care's position as strong partners in this system. So it's been an ongoing process now for quite some time involving leadership in both organizations.
Thank you. This year was the year of access, and you had long wait times. So how has that improved over time, and where are you at? So that's one question, and then I'll follow up with the next one, so.
So thanks for asking. We actually just reviewed this as a system leadership yesterday. We have seen, in general, our new patient access improve by nearly 37% across the community care system. And when you look at the specific locations where we did the targeted improvement, we've improved by nearly 60%. And that is dropping wait times at their worst in the North Central Family Medicine Clinic, which is such a high-demand clinic. From 95 days, we've brought it down to, I believe it was 47 days. So we've made very substantial improvement. We have not hit in all areas the 14-day goal that we have set for ourselves, but there are a number of service lines that specifically have reached that level. Pediatrics is one example. Hospital follow-ups is another example. So we've made really substantial improvement, and we actually put the brakes on midway through the year because we moved so quickly and we generated such incredible improvement that it put undue pressure on our teams, and we're starting to wear out our teams. So we backed off a little so that we could understand how is the most effective way to scale this across the entire system. And we're now in the process of expanding that pilot site to 5 additional sites. And so we expect to continue to see progressive improvement in this last quarter. But I expect this will be a continued improvement effort for a couple years to come.
Okay, thank you for that. I know that you are planning on recruiting additional 40-plus FTEs, and currently you're also behind on additional recruitment. So I'm just not, like, in terms of the challenges to
Sure.
recruit, and I don't know if you've identified how you can improve it. And another thing, that's something that we've communicated to Central Health for their budget, is that what has been in the past, when they're allocating budget for certain providers, certain lines of services, they will allocate a percentage of that money, but by the time the end of the year, they have not expended that money, and that goes back to our reserve. So we wanted to avoid that, like at least be more I think conservative with your expenses. And I think if you knew up front that at least 50% or more that this line of service is going to come to play, then include it in the budget. If not, don't. If you need it, come back to us.
Thank you
And
for-
that was really an issue, like in the past, in a way we've had to increase our taxes because we kind of overestimated. And we do not want to fall into that trap again. So have you
Yeah.
mitigated that in your budget?
We have, actually. Thank you for asking that. And we took the similar approach this year. Last year, we expected to end the year at 600,000 visits. That's what we budgeted for. And we'll probably end somewhere around 550,000. We decided actually not to meaningfully increase the number of expected encounters so that we would have time to be a little bit more conservative on the onboarding. I will tell you that we've learned some very important lessons and have 20 providers expected to come on board in the next 2 to 3 months. So we're closing that gap with new collaboration and new strategies between our clinical leadership and the people department team.
Okay, well, thank you. I am gonna stop here, and I have plenty more questions. I'm gonna open the floor. Chair Rodriguez, we'll start with you. Thank you.
I have 3 questions for you. I think one, obviously, we're living in the era of affordability, and this board values transparency, accountability, responsibility, and dignity of the person. And when I see that you're describing a disciplined tax investment, where I'm trying to understand if you can help me square the whole mission-focused progress where you say you're serving 4% more patients, but then your constraint is that your encounter volumes remain below plan, 8.7% last month, 6.7% this month. I'm trying to square how your disciplined investment for growth, but your volume encounters are down. So to me, it's like I'm not just measuring community care around the budget that we give them, but also the outcomes and the impact. So help me square the fact that your encounters are lower than expected from last year, but you're asking for more.
So while our encounter numbers have grown, what we projected to be with the last budget, we projected to be able to achieve a certain amount, and we are underachieving that one. So it is a growth year over year, but it's not as much as we had expected to or hoped to be able to get at. And for this reason, much like what I mentioned with Manager Musaitif, we've actually scaled back the ambition of our growth over this coming year so that what we think will more realistically reflect what we're going to be able to achieve.
So the second question I have is around transparency. So you talked about improving financial resilience and about the additional net investments that you're asking for. Where's the transparency about the revenue you're going to receive? Because I see all the nets here, but where are you holding yourselves accountable or responsible for the revenue piece? Because we can give you tax dollars, but it's not infinite. And so I'm trying to figure out the responsible way to view I don't want to call it a lack of transparency, but where is the transparency to the revenue pieces that you're expecting?
So we have built this budget to essentially be a net neutral budget, to be offset by all the additional revenue. And there is additional detail that was not provided in this slide deck that we have available, and we'd be happy to share, that shows how that revenue balances it out.
And I think the last question I have, and it's really more for the board around governance, but why is it Central Health's responsibility to add money on maintenance of effort to community care? Like, why isn't this squaring, like, for example, if you're getting $98.8 million and you're not meeting the encounters, why aren't you taking the savings in that money and just utilizing it there so that we're able to be more transparent, accountable, and responsible to each other about what it is that we're getting for those dollars? So, for example, in my mind, if last year we gave you $98.8 million and this year we're going to give you $117 million, but we're going to get less in volume, that makes no sense to me.
Sorry, not less in volume. We'll continue to grow
Less in
our volume.
encounters that
No,
you
we're going to
budgeted.
continue to grow our encounters. So for instance, our encounter growth this year is more than it was last year. It's just under what we projected it to be. But you're asking a very fair
Right,
question.
so it's a transparency issue about budgeting, and the budgeting that you didn't quite hit the mark.
Correct.
Got it.
And then, but you asked a really important pointed question, which is where are the additional controls that community care actually owns to be able to optimize within its own system to offset additional investment that Central Health might have. There are two factors to it. One, above and beyond our current work, we think we can get any new work done for $1 million. We should own the internal optimization and transformation and budget growth with the money we already have. So it's apart from the budget transfer, which is the $7.8 million or $7.9 million, and the maintenance of effort, which reflects costs that we don't have control over in terms of market, salary, contract adjustments, et cetera. We have put it upon ourselves to solve those problems themselves. But then there's, just candidly, it's a little bit different to be an FQHC in a system like ours, and we're incredibly grateful we're in this situation. There are types of investment and support infrastructures that an FQHC would not normally do if it were on its own, but because we are part of it, we are more than willing to help bear the additional cost in salaries and additional support services. And those are a bit out of our control, but we do, through very, very close partnership with Central Health leadership, to ensure that that is reflected appropriately in budget support. So we are trying to solve a great deal without actual additional requests of this board, while recognizing there are certain things that we don't have full or total control over.
Yeah, and I really appreciate that, because I feel the same thing from a board governance perspective, because really what you're dealing with is the standard terms and conditions with the administration, not with the board. So the board gets to oversee the budget and approve it, but the standard terms and conditions around which you're not having control, we don't have control either. So this is the opportunity to ask questions about those
Yeah,
kinds
absolutely.
of transparent, accountable, responsible things
Yeah,
that we're doing. So
thank you for those questions.
Yeah, thank you.
Any further questions? Dr. Martin?
Thank you for the presentation. And kind of segue into what the previous managers have said, I think that this year, as the data we got from Sendero and the loss of the ACA by so many patients, y'all are going to get hit pretty hard. And it says this is a year of access to care. Are there still, I guess there are, but what is the main limitation to bringing on new primary care doctors?
There's certainly a supply. The local medical schools don't generate a huge number of primary care doctors, but we have an invaluable partnership with Dell Medical School, which does actually, I think there may be 3 coming on board from the family medicine residency this year. I may be wrong with that number, but I believe that was this year's recruit group. So that has been invaluable. But frankly, medical schools are not producing primary care doctors at the rate we would like. Primary care is one of them. Women's health has been one that's been even harder for us. And there are a number of conditions which have to do with the relationships between and the scope of services. Too complex for this conversation, but between obstetrics and midwifery, and what the schools are and what the political climate is that would encourage people to work in this area. That has posed a problem for us and all of our peers in Texas as well. So we are looking to go to the route where people are in medical school and even deciding what fields they want to get into, help encourage a long-term investment. This is going to take 6 to 8 years to realize that investment in the long run, but we have to start building those relationships now, presenting this opportunity that people want to build their careers around. And we've been very fortunate to have very strong partners in a number of regional medical schools. Actually, thanks to Dr. Schultz and some of his work, forming relationships with medical schools, not just in Texas. But those are some of the levers we're trying to pull.
Right. I mean, it's just intensely rewarding work for doctors. And are salaries still a limitation?
No, we've actually had pretty favorable salaries thus far. And again, great deal of thanks to our finance and our people team for helping make sure that we're staying ahead of the curve.
Okay. One last thing. You mentioned you had high turnover with APPs. We all know that to lose someone after a year is intensely expensive.
Intensely so.
And I'm sure you're doing this, but what efforts you're doing exploring, you interview physicians and what they hate is paperwork and the computer. And I mean, are y'all discussing that how can we relieve this burden to retain the APPs and or the physicians? I'm assuming you are.
Yeah, and we're using technology of every sort to try and offload the burden on our providers. We've extended the onboarding process from what had been a year and a half ago, 6-week onboarding, to now 6 months or more. We also are being very selective on the level of experience that we are starting to input. Medical or residency graduates from physician residency graduates come with at least 4 years of experience in direct practice under the guidance of a preceptor. That's not the case always with advanced practice providers. And so we've instituted mentorship and oversight practices that help people more slowly integrate into what is a very complex body of work in
Right.
doing underserved medicine.
Okay, thank you both very
You're welcome.
much.
Thank you.
I'll take care of that. And then you're going.
Okay.
Vice Chair?
Mine's gonna be real quick and short. When does your board approve your budget?
So this is the catchball process. We go back and forth. So our board saw the preliminary budget last night and approved it. It will come to you all ultimately for final approval. This is the first time you get to look at it. We get the feedback a little bit. It'll come to you all for final approval in September before it then goes, for your entire budget goes to the Commissioners Court for approval, at which point your approval comes back to Community Cares Board for final approval at the very end of September.
So essentially, your board has already seen one draft, you
Yep.
could say, and they've approved that.
Yep.
And then there'll be another draft that they'll be approving in September.
Yeah, which basically they will be ensuring the final product that comes through the central health approval, the Travis County
Yes.
Commissioners Court approval, still meets their merit, and then they do the final sign off.
Okay, thank you very much.
Yeah.
Oh, one last question. If your board makes a change to the budget, to its budget, based on your presentations and their needs, et cetera, do those changes come back to us to review, or they
Yes.
do? Okay,
Yeah.
all right, thank you.
Manager Kitchen?
A couple of questions.
Yes.
So the first one is, can you speak a little bit more on what you anticipate your role will be in covering people that are losing coverage?
Can you say that last part
Well,
again?
people that are losing coverage, under the changes we've seen at a federal level. Do you see that impacting you primarily in increase in the need for encounters, or just speak to us more broadly about that?
We have some objective data. We have a lot of subjective data. So the objective data is we continue to see decline in Medicaid enrollment as a percentage of our total payer mix. And we think that represents subjectively what we've heard is a reluctance in certain cases for people to actually go through the government enrollment process for fear of exposure for one reason or another. We see anyone without regard to their ability to pay, and full stop there. And which means, though, that either people are coming in with the need to be screened for an additional coverage, whether that's MAP, or if they don't qualify for MAP, a sliding fee scale option. We are watching this very carefully month over month and have found ways to adapt to it, and we feel like we will be able to manage this over the next year without the additional investment of the $1 million for transformative work, using the maintenance of effort and the budget transfer we have currently.
Okay, because, and tell me if I'm thinking about this wrong, but so you may see an increase in encounters because of the need continues to grow, but a change in your payer mix, which could mean that you have less ability to cover those encounters because your payer sources are being reduced.
Correct.
Is that the right way to think about it?
Yeah, so we may have, another way to say it is we may have expected costs, but reduced revenue to offset those costs.
Okay. Okay, second question then is, I wasn't sure from the budget, are you all expanding the types of services in any way?
There will be, most of the investment work that we listed in the strategic investments are pilots that we've already done. So I
Okay.
would consider it expansion of new services. For instance, the medical dental integration is one of them.
Okay.
But for the most part, it is scaling what very broad services we
What you
frankly already have. Yeah.
And you provide some specialty services,
Yes.
right?
Yeah.
Okay, the last question, I'm not sure if it's, if you can answer it today or if it's a later question, but I'm curious, as we look at our central health budget, what process you all follow to determine whether new services, such as new specialty services, are provided through CUC or through adding to the services at Central Health?
Great question, and this is actually an ongoing conversation that we have pretty much every week with our community care leadership, Central Health leadership, sitting together, trying to figure out sort of one piece at a time, what is the best location. And there are a number of things we weigh. One, regulatory requirements. Two, financial advantage. There may be reasons why it's better suited to live in the Central Health environment. It may be reasons why it's better suited to live in the community care environment. In fact, we've come around to some agreement on a couple of specialties, for instance, in the Hancock space, based on that type of logic. So we're being very careful to make these decisions, knowing that while we can always change locations, it's pretty cumbersome to try and transfer from one region to another. And so we're being very, very diligent to take our time to make sure we land this in the right way.
Okay, well, that'll be one of the questions that I have regarding the Central Health budget, because the Central Health budget has some increases in certain services, specialty care, certain specialties being one of them. And I just want to understand what kind of process was gone through from a decision-making process to determine where those should sit.
Yeah, we have a committee that sits together every week to talk about integration efforts.
Yeah, I'm going to want to know if there's agreement on that committee.
Sure.
Thank you.
Okay, thank you.
Manager Jefferson?
So I want to follow up on the question regarding encounters. You come up with a number of encounters you project to see every month, and I guess that's based on a per provider type ratio. And so it is, I guess, it's some kind of efficiency measure.
Yeah.
Is that measure based on any kind of benchmarking? Is it just a matter of dividing, the cost of running things by this, or is it based on some like targeted?
We do
some
actually,
target that you would see in the industry?
yeah, it's a great
in other
question.
clinics.
Yeah, it's a great question. I'm going to take a first stab, and then Joy's going to give a much better answer. We actually use an internal benchmark. We look at, among other things, what our patients have historically required, pediatrics versus adults, et cetera, and project with the same demographic that we expect in the next year, what would that correlate to? So for instance, if an adult requires 3 to 4 visits per year, what does that translate based on the number of adults we have in this coming year?
Oh, there we go. So yeah, it's what we do is we look at actually kind of MGMA and some other national benchmarking to say that a family medicine doc should probably see about 3,200 or 3,500 patients a year, say. And then we take that times the clinical time that each provider has to actually see patients. And then we also back out vacation, holidays. So we come up with a number of days per year that our providers would see patients. And that really becomes their target of what we expect them to achieve. And then we balance against that target every month to see how they're actually performing. So there's a couple things that could drive us to underachieve our goal or our budget. Could be that providers are kind of lagging a little bit behind where we thought they would be. Could be open provider positions that are driving that to be a little bit lower. But we have, we base it on some really solid data of what industry standards would say these internal medicine or pediatrics or family medicine providers should be achieving, specialty providers should be achieving.
Okay, I have a couple more questions. So, and I'm glad it's based on something a little bit more objective versus this is how much it costs, but getting to cost. So I heard a question too. I know that the aspirational amount of encounters is not, we've not met that, or you've not met that. And so under this new budget process, which it looks like it's kind of working, is there a true-up at the end? Does community care keep the money, or does the excess come back to us at Central Health?
So the way that the process is working, this is of course our first year into it, is that there is kind of an assessment throughout the year on how well community care is doing, what we're doing with any excess that might be building up if we're not achieving our expense goals, or if we are not spending the money that we'd planned on spending. The commitment has been to make sure that community care doesn't fall below 30 days cash on hand. And so we work within that measure to see what do we need to do. This year, we were on target for a surplus. Moving the shared overhead cost into community care will likely end us in a loss for this fiscal year. So it's one way of being able to utilize those dollars in a way that benefits the system as a whole. And I think it becomes then a conversation mid-year as to how we're performing.
Okay, so it sounds like, to me, there's really not a surplus if you have to cover the cost of the shared expenses.
Correct, for this
Okay.
fiscal year it is.
Okay. All right, so, and that goes to the last question that I have. So when I look at the one page where you have the 98 million for the FY26 and the amount that's being requested for next fiscal year, and then you have a certain amount for maintenance of effort. And maintenance of effort, you mentioned that it includes, salary increases and other things. As I, having been on the community care board, so the salaries, this is based on a compensation structure that is done in collaboration with Central Health, so that if whatever the X amount of the salary increase bucket is for the Central Health staff is going to be the same for the community care, and other things, infrastructure costs and all of that. Is that all that's wrapped up in the maintenance of effort?
Correct.
So that number is just really keeping on pace with what I'm going to expect to hear from Central Health later? Is that?
Yep.
What, okay. And then the shared
Joy
system.
had one comment.
Okay, go ahead.
I mean, I think the additional piece for our maintenance of effort is we also took into account the decreased pharmacy margin due to 340B continued stressors. So, and we also had to increase substantially some of our lab cost for patient labs. So there were a few pretty high drivers that hit that maintenance of effort for community care in fiscal year 27.
Okay, that's good to know. And then the shared system overhead, that amount, that appears as a new amount, but I thought we were hearing reports since I've been at this board table about how there was an accounting change or something like that, and you all needed to reflect that, which makes sense to me because, your financials should show the true cost of your expenses, and that's part of it. So, and this gets into like shared enterprise services with IT and that kind of thing. But why is that such a big number for FY27 if you've already had to account for it this year?
Well, it's the same as what we're putting, so we're recording the 7.9 million in fiscal year 26. We're recording that now, and then it's the same amount carried over into next year, but it wasn't a part of our budget. And so it wasn't a part of the 98.8 million that was contemplated for fiscal year 26.
I see. Okay,
Thank you.
thank you.
Thank you. Dr. Brunson, no questions? Manager Valdez?
So we know that there is going to be some impact on some of our populations driving themselves to their appointment, their clinics. Is there going to be a way to determine what that impact is actually going to be and whether or not there should be a change in how they are routed to specific clinics in order to access those particular services that they're needing? Let's say that they're initially all primary care as opposed to more adult service needs. Is that going to be taken into consideration, or are you also still waiting for the finalization of your community assessment data gathering information?
The community assessment will certainly help us a great deal in understanding where preferred demand is and where objectively it looks like we need to invest more deeply. But we are getting some signals in terms of interest in alternative ways of getting care, if that's what you're
Yes.
asking about. So for instance, we actually track, for instance, the percentage of no-shows or cancellations that can be converted into telehealth appointments.
Right.
Maybe people didn't want to come to the clinic.
But they will see you online.
But they will see us online. And we've been optimizing workflows and seeing really great improvement in that performance. So we are being able to increase access. Again, this is not new FTE, this is not new technology. It's using the services we have to be just all the more flexible to create those access points. But I'll be honest, I'm not aware that we've done any analysis about any regional specificity to that type of behavior, that interest in converting in-person appointments to virtual ones, but it's a worthwhile question.
Okay, I thank you for that. Again, with respect to the services that are being offered in particular areas, are those reports being made to your board, you know, on a monthly basis so they can see whether or not that particular clinic is actually on target to provide the services that they're doing for the visits?
Oh, yeah.
As opposed to an under achievement of the goals that they have met?
So we are tracking that very
I
closely.
guess for the usability.
On a weekly basis, and then doing a monthly review as a senior leadership team. We tend to not bring the specifics of each site to the board every month.
To your board.
To our board
Because it
every
doesn't
month.
come to our board.
Right. And actually, frankly, the site-by-site breakdown.
Yes.
We usually manage as staff, not at the board level. But were we to encounter any particular trends that were of great concern, and so there will be certain moments where we'll highlight for the board, we think we need to make a strategic decision about a
Right,
particular
right.
site because of either too much access or
Not
too little
enough.
access. And as an example, we've talked to them about the North Central clinic, which is in such high demand, we are trying to make investments to offload some of the pressure that location feels, like the Northview location that we're developing together.
Thank you.
I appreciate it. Just if you can let us know if there are going to be any significant changes prior to the
Of course.
next budget,
We'd be happy to.
addressing those costs. Thank you.
Thank you, appreciate it. Thank you for your time. I do have actually one question and a comment.
Great.
The question is, it's really simple, yes or no, and then we can go in the future. For specialty services referrals for community care, where are they usually referred, the first option for specialty services?
For community care patients, particularly for MAP and MAP Basic or unfunded
For all
patients.
community care patients in general, what's a rule of
Well,
thumb?
patients have choice, and we offer them whatever choice they would like. We try to drive as much care into our community care and central health specialty practices as we can.
So if we want to close the loop, if you want to be like a system, like for instance, a Kaiser Permanente system, like really in terms, couldn't we determine for the payers, like this is your first primary option rather than giving them a menu of services? I'm just wondering, like, because I know there's certain health systems.
Network payers can set up networks for whom they will pay for services to be provided, and those are certainly levers that the MAP program, who contracts with only specific providers, not everyone in the community, and Sendero does as well. But you're asking a really strategic question about how do we start avoiding what we might call leakage, where patients end up outside our system where we have less control over costs and quality, et cetera. And ultimately, we would like to design a system that has the capability and capacity to serve all our patients internally.
And the reason why, if we're investing the significant amount of money, like we just need to think about ways how we can control, and we're expanding specialty service. It's not that we're not offering. So I would hope that the first line of referral will be to our specialty services, giving the types and the quality of providers that we were recruiting.
Absolutely.
And so that's one. And last comment, just something for you to, food for thought, given where we are in terms of our budget and all our limitations and constraints, if you would have to think about cutting your budget in what area would that be? You don't have to answer me that, you don't have, just think about it, because,
We are.
okay, so just keeping that in mind. Thank you all, we appreciate your time, and we look forward to our continuous conversation. Thanks for all you do.
Great, thank you.
Thank you. And we are moving on to our third budget discussion, which is item number 3, receive and discuss a presentation on the proposed fiscal year 2027 tax rate and budget for Central Health. This item will be presented by Dr. Lee, Jeff Canoto, and Nikki Riley. Beforehand, managers, this is the first time that we will be seeing the proposed budget and and just note, nothing is set in stone. This is the first time and an opportunity for all of us to observe and look at the different scenarios, and we'll have multiple opportunities to input related to the budget. And they have prepared 3 different scenarios, and there are scenarios in the backup material as well. And over the course of this budget cycle, there will be multiple meetings throughout, primarily August and September, until our final approval is. Now, as you know, in our budget, there's a timeline of the dates that we are going to be meeting and revising this budget. And as you know, this budget is the first step, and it's been, I don't know, how long have you been working on it? Yes, it feels like that, but also just keep in mind that it was really based on community input, on patient needs, on community, on all our health, based on our strategic plan, our health equity plan. So there was a lot of evidence behind it. And also, I just wanted to make sure that we're all on the same page when it came to our CBO funding. We all agreed to where we're gonna head for next year, issuing the RFPs. And if, I think management wanted to know if we're all if there's any comments or anything related to that item.
Did you want that now or later?
No, you can later, if you have anything that you would wanna present to us. I just wanted to bring that. And also in terms of this budget, it does not include any board members' recommendations. And from my understanding, there hasn't been any recommendations. We just don't want any surprises. If there is anything that you feel that this budget is missing, let us know. But I think this budget is very comprehensive. It includes a lot of needs assessment, So with that, I am gonna open the floor. I believe Dr. Lee will start, and we look forward to this presentation. Thank you.
Thank you, Chair Satif. Good evening, managers. Tonight, we're taking the next important step in developing Central Health's fiscal year 2027 budget. Our team has prepared 3 possible budget scenarios for the board's consideration and input. And today you will see those scenarios presented side by side so you can understand the choices and implications associated with each. We're not asking for any action tonight, but we are seeking your questions, your feedback, and any sense of direction that you would like to see us pursue as we continue refining the proposed budget. Hopefully you've already had an opportunity to review the detailed budget memo that was included in the meeting backup, and I want to thank the many team members who participated in creating that memo. This is the first time that we've put it together like this for the board, as we look forward to your feedback. And that memo provides quite a lot of detail, background, and context for tonight's proposal. It summarizes the process that we use to develop this budget. I heard a number of questions on that, so we provided some detail about kind of how we made the sausage here. And it outlines the strategic and financial considerations associated with each scenario. Now, each of the 3 scenarios presents a different balance among the tax rate, the use of our reserves, and the pace, scale, and sequence of the work that the board has directed through the Health Equity Plan and the System Transformation Resolution. The scenarios differ, but the goal across all 3 does not differ. Our goal is to improve access for the people we serve, to strengthen the healthcare system we are building, and to responsibly manage the public resources entrusted to us by Travis County taxpayers in building the comprehensive system that the board has directed. So as the team walks through each scenario, we invite you to, at the end, if you don't mind, ask questions, identify any additional information you need, and share your perspective on the direction you believe staff should take as we move toward a finalized budget and proposed tax rate. And so with that, I'll turn over to Jeff and Nikki to get us started.
Thank you, Dr. Lee. Chair Masada, thank you for opening up. You took a lot of the words that I was going to plan on speaking to. This is our staff initial proposed budget, and there are lots of opportunities to submit questions internally, submit questions through discussion, and staff will respond to those questions in subsequent presentations. But we want to make sure that we answer all the questions the board may have related to this budget. Let's see, next slide, please. So just kind of teeing up our agenda, today's presentation follows our budget development process from planning to tax rate options and long-term financial impacts. As Dr. Lee mentioned, we'll review 3 budget scenarios in addition to strategic investments, system integration processes, system risk, long-term reserve, forecasting, and taxpayer impact. And just as a reminder, there was the memo in the packet. Just as a technical note before we get started, we never seem to receive the certified tax roll in a time where we can update numbers for presentations. We may have some slight differences between the memo and the presentation. We try to incorporate the certified tax roll, but we've just recently received it, and so we still have some work to do on that. So that's really just short for, we'll have some changes as we true up to that, and we complete our truth in taxation process. Next slide. So this is a diagram of our annual planning and development cycle related around the FY27 budget, and it's a result of a year-long process that links strategy, performance, and funding. There were a number of board actions that were taken to help establish this process, including the FY27 driving forces, objectives and key results, and system transformation resolutions that began before the budget development process. Strategic initiatives included in the budget were specifically designed to advance the board-approved objectives and key results, and this process ensures that investments are tied to measurable outcomes rather than just standalone programs. And so just looking at the diagram, you see some of the upfront processes that occurred as you move from 12 o'clock down to 6 o'clock, and then you notice the "we are here" part that we're just starting that process. Next slide, please. And so speaking of budget refinement and processes, this is a subset of that one box that we were in. This is how our budget comes together within that box, even though at times it may overlap some of the timing of other areas. The current presentation represents the preliminary budget phase where strategic investments and tax rate scenarios are evaluated. We move in the process as we deliberate and have additional public meetings where at some point the Central Health Board will approve a proposed tax rate in a public hearing. And I just want to pause for a second. The proposed budget for the proposed hearing and tax rate for the budget is not the final rate. It's just for notice purposes. That's the middle box. And then, of course, we go through the budget and tax rate approval process with both the Central Health Board and the Travis County Commissioners. And then there's a last step that, that financially speaking, we go through, which is the budget publication and the submission to the, to GFOA, Government Finance Officers of America, for submission and consideration of the Budget Excellence Award that we've been awarded, I believe, 7 years in a row. So that's an important process just to complete the budget process related to the Central Health FY27 budget. Next slide. So as Dr. Lee mentioned, staff has prepared 3 budget scenarios for FY27, each one with a different proposed tax rate. Each scenario represents trade-offs between taxpayer impact, continued investment in implementing the healthcare equity plan, strategic priorities, and long-term financial stability. Both the 8% and 6% scenarios preserve the full $27.3 million of proposed strategic initiatives. The key difference between these scenarios is property tax revenue and reserve levels. The no new revenue scenario requires significant reductions to initiatives in healthcare services while reducing reserves below staff targeted levels. The 8% scenario maintains reserves within the within the long-term target range of 120 to 150 days by fiscal year 31. This provides the greatest flexibility to respond to future needs, including healthcare investments and economic uncertainty. The next 2 slides will give us a little more context around these rates. So I'll turn it over to Nikki for a few slides.
Good afternoon. Nikki Riley, Deputy CFO. Continuing on the hospital district tax impact comparison slide, most of you have seen this slide before. What it does is it compares Central Health to the larger hospital districts in Texas, showing the percentage of the hospital district's tax burden on their respective county. So this is all the taxing entities that are in Travis County. Central Health represents 5.73% of that county's taxing authority. Central Health does not own a hospital. We're not having to pay for a hospital, which is why we're at 11.8 cents. And all of the other taxing districts, hospital districts, are much higher, which is why their percentage is also higher. Just for awareness, the legal ceiling for regular hospital districts that own a hospital is 75 cents, and for Central Health, it is 25 cents. So we're still significantly under our legal ceiling. Next slide, please. This is a history of Central Health's tax rates compared to the taxable assessed value by tax year. Tax rates and tax values have an inverse relationship. When appraised values increase, you'll normally see tax rates decrease. So that they call it the effective, or they did call it the effective tax rate, or the no new revenue rate, that will get the government the same revenue as the previous year. And then from that point, they decrease taxes. So this shows, you can kind of see the history of this. In 2012, Proposition 1 was approved, which was the Dell Medical School. So you can see in 2013, even though appraised values went up slightly, the tax rate went up significantly. And then recently, you can see where appraised values went really through the ceiling in 22, 23, 24, and 25. So you can see where the inverse happened with the tax rate, it decreased. Next slide.
Okay, I'm gonna take this slide, and apologies, it might be a little lengthy. I think there's some detail in the memo, but I'll be happy to send out our summarized bullet points that I'll go through. I'm going to talk about a lot of amounts that are sequenced throughout the objectives. So the objectives, as we discussed, will deliver better care, quality, and access, improve patient experience, and driving better patient outcomes. Together, initiatives proposed for the FY27 budget support the board's vision of comprehensive and integrated healthcare system that provides better value for taxpayers. Important to note, initiatives represent investments to expand, scale, or stabilize patient services and operations. This slide provides, as I mentioned, a high-level overview of the initiatives organized under the board adopted objectives, otherwise known as OKRs. Both the 8% and 6% scenarios represent key investments to advance the healthcare equity plan directed in the system transformation resolution that totals $27.3 million. So starting left to right, with the objective, create seamless care journeys, the $18 million investment to improve access, reduce wait times, close identified clinical gaps, including hiring approximately 17 additional providers and program investments, including general surgery, podiatry, nephrology, cardiology, dietitians, outpatient, occupational therapy, and mental health, among a few, at the Travis County Jail, and unhoused patients related around community care bridge team. $1.1 million to launch a rapid access clinic, including a staff of 12, and equipment for urgent care and follow-up for post-emergency department and hospital discharge. And $400,000 to expand field-based eligibility support at shelters, including SOAR disability application staff. Next, the $2.6 million amount under Empower and Develop Our Team represents investments from insights from our Big Listen survey and staff town halls, highlighting professional and workforce development as a key priority. Investing in the people, leadership, and capabilities at Central Health to make our people that provide our care the important aspect of how we deliver care. Investing in clinical education, establishing a simulation lab, digital certifications, and a continuing education platform. Implementing an enterprise learning management and talent development platforms related around our continuous improvement team training, workforce support infrastructure, including functions and systems to reduce operational and compliance risk, including artificial intelligence benefits, management tool, new FMLA leave management tools, and improvements to employee health plans and well-being programs. Implementation of finance and procurement software to increase efficiency and enhance reporting. The next objective is on demonstrating the value of community support, is focusing on strengthening stewardship and diversifying revenue. In our budget, there's an initial investment and startup phase of the board-approved Central Health Foundation. And then also enhancing revenue cycle capabilities, including reimbursement and compliance. And just as a footnote related around revenue cycle, we were recently, our Medicaid application was approved. So we're looking forward to continuing building up our revenue cycle teams in order to provide services to our Medicaid population and partnering with community care in that process. The breakdown of that is there's about a $912,000 investment related to the foundation and about $400,000 related around the Medicaid application approval and revenue cycle initiatives. And then the last one on the right, building a comprehensive and equitable system. Those include achieving critical infrastructure milestones, including opening phase 2 of Hancock, strengthening data related to EPIC data modeling, artificial intelligence monitoring, threat detection, cybersecurity analytics and technology platforms, and then enterprise support functions, including facilities technicians, including skilled trades, supply chain procurement, and related expertise. So the breakdown quickly of that is $4.4 million in artificial intelligence and cybersecurity, $700,000 in scaling our facilities and supply chain management, and $300,000 to stabilize our procurement team in adding facilities procurement expertise. Next slide.
Jeff,
Yes, ma'am.
I just want clarification. You are going to be providing us with the detail that your words, the
Sure,
words,
yes.
the words you're using, but not that we see here.
Yes.
You are, so you're going to be sending that to us.
It's in the budget memo, but we'll also provide a detail on what I'm going through.
Yes.
Yes, ma'am.
Thank you. I appreciate that.
This slide is our current look at our FTEs, full-time employees, as of June 30th. This shows the programmatic FTE count trend by month as of June. So we also have the programs, the numbers in the colors. Administration is the bottom one in green. And then orange is our direct services, healthcare services in the middle. And the blue on the top is our healthcare operations and support. And it just shows how how we've been filling the open positions. And at the beginning of the year, we had filled positions of 779 positions, and now we are at 874 positions. This chart also shows the percent of filled positions to budget positions as of June. So the top right chart by program, it shows you in June how many positions were filled by program, and then it shows you the budget of FTEs that we have. So let's say for the admin program, we budgeted 162 positions. We now have 150 filled, which is 93% filled. Direct services, we have 76% of those positions filled now. And then healthcare delivery operations, 90% of those positions are filled. The bottom right corner is showing the proposed fiscal year 27 budgeted FTE count by program. It does include the new positions that are being requested. Plus, it also includes 26 positions that are being transferred over from CUC This is in accordance with our transformation resolution that the board adopted. We are combining our EPIC employee team to be able to better serve our patients fully so that they are able to go into, let's say, Hancock Clinic and easily go into and check in with whoever they want to through Epic, regardless of whether they're a central health employee or a CUC patient or central health patient. So there are 9 new positions for admin that are being asked for. If you take out the 26 positions that are transferring over to direct services from CUC, there's 103 positions that are being asked for direct services and 12 for healthcare delivery operations. Next slide.
So the next slide talks some about our system investment, our healthcare system related to central health, Sendero, and community care. Across our health system, significant investments are required to provide healthcare coverage for our patients. In 2026, Sendero membership doubled to 35,000 overall. As a community-based health plan, Sendero is required to maintain certain levels of capital. These levels are regulated by the Texas Department of Insurance to ensure sufficient capital exists to maintain licensure. For FY27, Central Health anticipates an investment of $30 million to maintain these required levels of capital in anticipation of final risk adjustment payments for Sendero's calendar year 25 and anticipated financial results for calendar year 26. And just as a reminder, their fiscal year is a calendar year. Additionally, fiscal year 26 Affordable Care Act premium subsidies were evaluated, and they were right-sized to Central Health's anticipated premium subsidy spend that we budgeted for fiscal year 27. This budget will maintain the current programs and membership levels that are currently in place for those premium subsidy programs. For community care, expanding access to primary care is the focus, with additional investment in creating more bandwidth and additional internal capabilities. These internal capabilities will provide more control of critical functions that help protect the health system from dependencies that impact cost, revenues, and patient outcomes. For fiscal year 27, planning for in-house lab services has been identified as one of the areas that will facilitate that patient testing and help control cost and dependencies. Dental health is another opportunity, with additional funding for hygienists and dental assistants and care coordination for high-risk patients. And then at the bottom of the slide, we're showing some of the progress that we've made as it relates to building an integrated system. To the left, you see some of the areas that have been completed through our integration process. And then on the right are some areas that we're making progress on. We're not quite completed, and expect to continue those for the rest of 26 into fiscal year 2027. Next slide, please. So this is a system risk slide that we showed at the forecast, just raising it again to for awareness, and just as it relates to how we look at risk and we evaluate maintaining adequate reserves. These risks are not prioritized. They represent system-wide risk in the healthcare system that could affect Central Health, Community Care, or Sendero. Reserve flexibility helps protect operations during volatility while, excuse me, while supporting future strategic investments. Next slide.
This slide, you'll probably recognize. Attachment A is the summarized version that we put together for our published budget. We do have all three scenarios compared to our fiscal year 2026 budget. As you can see, the revenue growth is what's going to be the main difference, in that with the no new revenue rate, the only new revenue that we would receive is the new construction, which comes out to about $6 million. And then the 6% budget comes about $34 million. And then, I'm sorry, $21 million. And then 8% is an additional $34 million. The numbers that you see over here, 47.7, 40.3, and 18.3, that also includes the debt service tax rate. And so the new revenue for M&O operations is commingled in that debt service rate. All of the scenarios are the same as far as the revenue, the other revenue. Tobacco settlement, we increased it by $2 million just based on past yearly trends. We increased that by $2 million. Last year, our budget was $5 million. I believe this year we received a little over $7 million. We did increase patient revenue. As Jeff mentioned earlier, we were just approved by Medicaid, and so we're looking forward to that new revenue next year. Plus, we just started our Medicare billing this year, and so we've been increasing that as we've been seeing more of those patients. And so we've increased that by $2 million as well. Healthcare delivery on the expense side. Oh, I need to explain, I'm sorry, the other financing sources. So if you remember, the board approved a debt issuance back in December. It did fund 4 projects: Colony Park, Hancock, and the purchase of 2 buildings, Northview and Promontory Point. But we were able to be reimbursed for cash funding that we had funded for a lot of the Hancock projects, some of Colony Park, and the purchase of Northview. And so we were able to, and Promontory Point, we were able to reimburse ourselves for all of that funding, which comes out to $91 million. So when we received those debt issuance proceeds, we're able to take that money and we put it into this budget. Also, on the expense side, healthcare delivery is the most increase. I'll let Jeff explain that in a little bit more detail in Exhibit B in the next slides. But all of the scenarios have an additional $30 million for Sendero, so they're able to have their risk-based capital that they need. And then all of the scenarios have the allocation to community care for costs. And so that's a lot of the reason why administrative costs decreased this year, is because in last year's budget, we did not allocate any cost to them. But this year, in this year's budget, we are. And then one more thing, in the other financing uses, last year, the $37 million, that in that budget, it was $15 million transferred to the capital reserve. That was before the debt issuance, and so we needed some extra funding for that, so that's what we budgeted. There was also a transfer due to increased expenses to the emergency reserve, the 15%. And then there was the $12 million to the healthcare reserve, which is the $12 million that CUC also carries on their books. This year, we do not have any transfers. We're not recommending any transfers to capital. We will have a little bit more transferred to the emergency reserve because of increased expenses. But then there's also $913,000 that we're transferring to the board-approved foundation. That's what is the budget, and so that will be the money that we will transfer to them. And that is in all of the scenarios as well.
Yeah, and if I could interject, on the foundation, that budget will come back to the board as a separate presentation. So just wanted to place mark that. Next slide, please. And thank you for your patience. I know this is a long presentation, and I'll try to speed it up a little bit. But there's a lot of activity going on in Central Health. So now we're going to get into a few more detailed of what we call Attachment B. This is our healthcare services that consist of both contracted services and direct services. So again, our direct healthcare investments continue expanding to align with the health equity plan. The bar chart on the left speaks to those direct healthcare services over a 4-year period. In fiscal year 26, our investment in network services increased primarily from our increased investment with community care, which you heard earlier. Some slight increases in behavioral health, including a $400,000 increase to integral care. And then there are some increases due to some declining opioid settlement funding. Network pharmacy is an increase due to specialty care volumes and some 340B impact that will require us to pay more for the same medications. And then the Central Health Investment Fund, the CHIF, is flat. Those are 2-year cycle of programs, and it's flat funding for FY27. As I mentioned earlier, by the end of Q4, Central Health will be onboarding approximately 17 specialty providers over the next 2 months, and I won't go through all those just for time purposes, but I will mention for fiscal year 2027, we anticipate reducing the gastroenterology, the GI wait list, from 1,000 to 200 patients, and pulmonology appointments to be available in under 2 weeks. Growth in these areas reflect in part are driven by the phased opening of Hancock, which is anticipated at the beginning of 2027, increasing depth of specialty care, navigation, diagnostics, respite services, behavioral health, and care coordination. Next slide. So this is our healthcare operations and support. Some of the major increases include the Sendero capital requirements, the increased annual debt service requirements, and then investments in implementing artificial intelligence, including standardization and compliance that will achieve more operational efficiencies and decision tools. And then further investments in cybersecurity to protect our healthcare systems from intrusions that can put the organization at significant risk of major healthcare service disruption and regulatory cost. We feel like these costs create an essential infrastructure necessary for a more integrated healthcare system. Next slide, please. This is our administrative and other uses. Administrative spending decreases despite some organizational growth and the offset, part of the offset that was discussed earlier. Some of the one-time fiscal year 26 transfers don't occur, as Nikki mentioned, in 2027. And the budget reflects continued effort to direct administrative resources effectively while maintaining appropriate levels of compliance, controls, and support for our clinical operations. I'm going to pause for a second. There is a noted, it's not an error, but it's something that got collapsed accidentally. So I do want to point it out. On the right column where it says transfer to emergency reserve, the 13902,418, somehow that got rolled up with the foundation contribution also. So the correct numbers would, there should be an additional line item related to the foundation contribution of $912,000. And then the transfer to the emergency reserve would be less. So we'll clean that up in the next presentation, and we'll note that change in a subsequent presentation. Next slide. So this is our tax rate reserve slide, and again, there are 3 scenarios that we walked through. In addition to that, there's the original healthcare equity plan reserve levels that were adopted in August of 2023. Up on top, the chart shows by each year from fiscal year 27 through 31, the dollar amounts. And I know it's always confusing between dollar amounts. Are we looking at dollar amounts or days of reserve? So dollar amounts are in the table up on the right, days of reserve are on the left. So the reserves levels that we're looking at can impact a number of things, including bond rating, borrowing cost, risk mitigation, and the organization's ability to respond to unforeseen or quick occurring events. All of our scenarios, other than the healthcare, the dashed line, include an 8% tax revenue increase for future years. So I'm talking fiscal year 28 through 2031 above the no new revenue level. The range of 120 to 150 days of reserves continues to be our target and is the basis of staff's recommendation to maintain a long-term view that ends within our targeted range. And just as a reminder, the initial healthcare equity plan scenario, the dashed line, was based on a 6.5% year-over-year rate. And based on the scope and the adoption of that plan, it stops at fiscal year 30. And so that's why you see it a little shorter than the other lines. This was the best estimate at the time, and some changes have occurred on the healthcare equity plan, including opportunist acceleration of services and some unforeseen ongoing costs related to our system. Next slide, please.
This is the median homestead taxpayer impact comparison. The updated values reflect the certified tax roll received after the budget memo was finalized, and so these numbers will be different than what is in the memo. The median homestead tax increase for the 6% would be approximately $26 for a homestead for the year. And with an 8% increase, it would be approximately $35 for each homestead, median homestead. The increase in the debt service is the result of the board-approved debt issuance in the amount of $249 million in December that I referred to earlier. Next slide. This is the proposed tax rate. The staff is proposing the 8%. This rate fully funds the proposed strategic initiatives that we've discussed tonight. It preserves the reserve levels within the long-term target range, which is imperative that we do since we just issued debt and we are annually audited on those by the same bond raters that rated the initial debt issuance. And it maintains flexibility to address any future needs, emerging priorities, like $30 million for Sendero. Those things are a risk that Central Health is constantly at risk to receive from our partners. So the maintenance and operation rate, it would go to 12.5244. The debt service rate does increase due to the debt issuance. Last year, I believe it was at 4% of the total rate. This year, it's at 7% of the total rate. Our debt issuance, our debt payments for fiscal year 27 are going to basically double from this year. So that's why that increased. And then the board has already approved the 20% maximum homestead, and then also an increase to the 65 and older and the disability exemptions to 197,000. That was at 185,200. And so they will see relief in any tax increase that we do have. Next slide.
Okay, so to wrap up, key takeaways related to the presentation, and thank you again for your patience. I know, again, this has been a long presentation. The preliminary budget is guided by both the system transformation resolution and reflects Central Health's commitment to executing the health equity plan, which is our 7-year roadmap to closing healthcare gaps for our patients. Staff evaluated 3 budget scenarios to present to the Board of Managers. Each scenario has its own attributes that address critical healthcare access services across Travis County while maintaining long-term financial sustainability and balancing taxpayer impact. The staff proposed 8% tax rate over the no new revenue rate advances the fiscal year 27 strategic budget initiatives and provides value to enhancing Travis County's safety net system. It maintains long-term financial sustainability and targeted reserve levels and preserves flexibility to respond to driving forces, operational needs, and financial risk. The board's continued guidance and support to advance the fiscal year 27 Central Health budget toward adoption and furthers Central Health's mission by caring for those who need it most. Central Health improves the health of our community. Next slide, please. This is the calendar of upcoming events and past events. And so we're at July 29th, the third column from the right. And as we mentioned, it's been mentioned a couple times, there are some upcoming meetings for further discussion of our budget. And then we're scheduled on August 20th to present to the Travis County Commissioners Court our proposed budget, and then coming back in September, in early September, for Central Health consideration, and eventually by mid-September to the Travis County Commissioners Court for a final tax rate and budget consideration. So thank you again for your patience, and
Thank you.
happy to answer any questions or receive any comments. Thank you.
Well, thank you. First of all, want to thank you and thank you for your time and effort for this long, tedious process. And we're still in the early phases, so bear with us. Thank you. We appreciate your time and due diligence. A couple things, board members. we're running out of time in terms of this, so, this is not the first time that we're gonna discuss this. This is the first time that was presented to us, but we still have a long time for input, throughout the process. So feel free to send your input to, whoever to the chain of usual the folks, and we'll disseminate that information. Just want to make sure that I lay that out once we're opening for questions. So the thing that really, what I'm looking at for instance, for example, attachment B. When I look at in terms of the expenses that what was approved in fiscal year 26 and what was expended year to date right now, many of that expenses did not exceed 50% the margin. And then yet, for fiscal year 2027, you're asking for the same or more. And that to me is quite concerning because I'm looking at our budget and where we're at. I am personally, as a taxpayer, I'm not in favor of increasing our taxes. Given where we're at right now, in terms of a lot of people are struggling financially, a lot of people are having a hard time. So I don't want us to be adding to their burden, financial burden throughout. So that is a deep concern for me personally. But I'm just looking at ways that we can alleviate that burden on our community and our constituents just based on just looking at the memo and expenses. So I don't know if there's clear justification in why it's to that amount. Why can't we, if we did not expend it by that certain amount, why couldn't we condense that amount? And if we need further funding, you can always come back to us. So that is, to me, that is probably, when I'm looking at it, is a significant portion of our budget. I'm just looking at attachment B. And when you're proposing the three different scenarios, for instance, the first scenario deficit is about 15 million. So I'm looking at where we're at expending, couldn't we conserve that somewhere here? So that is, I just want to point that out. You may not have the answers, but that is something that I will be looking into. So that's the first hand. I know I'm going to acknowledge Manager Kitchen in a second, but I'm just looking at that really, and you may not have an answer for us, but we want some justification and clarification how you can amend that, at least that attachment. Manager Kitchen.
I just had a related to, I was looking at page 17 or 12. I think it'd be helpful to have a budget to actuals line. So, because we're seeing the budget for this current, fiscal year
here.
2026, we're seeing the budget. Oh, is the budget to actuals?
Yeah, they have it separated, so that's why I was
What
going
page is it?
back
I'm
and
not seeing
forth. It was in the memo, the
Yeah,
actuals.
so
Is it, where is it?
In the memo, in the
Oh, I
backup
missed it.
material.
Okay.
So
Right.
that's where I'm referencing the percentages.
Okay, I see.
So can I
Yes.
interject a little bit? So we report monthly on budget to actual in our financial statement presentation. So that's the board report, if I'm understanding the question.
Oh, it's not in this memo then, it's in the,
Yeah,
It's in the
we
backup
we
material.
report, right, it's in backup. We did not have a agenda item to present it, but it's in backup. And that represents, financial statements through June of 2026, so 9 months, 75% of the year has elapsed. So it's not where we'll end up at year end. We have some, timing issues related around how things are paid. It's not exactly a straight line. I believe in our estimate, if I remember correctly, and I'm just going to do this off the top of my head, so I might be a little off, but we anticipate about an 87% spend related to our overall budget. And a lot of the spend related to budget and actual is in direct healthcare services. But those are services that were anticipated to be stood up and implemented in fiscal year 2026 that have been a little behind in the implementation process. But just going back to one of the talking points that I had was, we're bringing on board 17 specialists in the next 2 months, so that healthcare spend in the direct healthcare services
So
will.
with that, I'm sorry to interrupt you. If you said like you're bringing on board 17 specialists, so it'd be helpful to know which specialty line, because still
Okay.
there might be some opportunities in that budget. Because I'm trying, thinking about all our expenses, you're asking like community care presented early on for additional 17.5 million over from last year. We have another capital investment for community, Sendero, and there's a lot of expenses, so I'm just looking at us opportunities that within our budget that can continue to sustain the services. I'm not saying to shrink the services, absolutely not, but how can we modify, how can you be conservative in a way to have some savings, and especially that's a significant investment in our healthcare delivery. So that, I'm just gonna point out that, giving the time allocated, I'm gonna open it for, managers. So managers, if we just can go just really quickly across, and we'll bring this back, and we can communicate via email, if you have any further questions. So I'm gonna start with Manager Jefferson and go around the room.
I do have questions, but I'm okay with submitting them in writing. Do I just send them to you too? Is that how it is?
If you can copy Perla, and
Okay. Send them to Pearl and she'll route them.
or
I
the
do
liaison,
have some questions.
liaison, whatever they emailed that new one, liaison, okay, thank you.
Okay. Yeah, I think I'll leave it at that.
Thank you, Manager Kitchen,
I have one quick one, and then I'll
Yes.
send the rest of mine the same way.
yes.
Can you tell me where I can look in the budget for the CBO funding?
It's spread out a little bit. We'll come back with a discrete schedule on that in the next.
And my understanding from our last conversation about it was gonna stay at the 5 million level total, and that we would be
That's a
issuing.
policy.
Yeah, it would stay at the 5
It's a-
million. I
it's
just
a-
wanna see where it is and what the list of it is.
Okay.
Okay.
Thank you. Dr. Martin?
Thank you for that very thorough presentation. A couple things. What would the effect? I saw that healthcare delivery costs is 6 and 8% essentially, or expenditures remain the same. So what is the effect on our bond rating if we are at 6% versus 8%? I saw that kind of to mid 2030, they're within that range. So just at 2031, is it dip? What is would there be a bottom line effect in terms of bond rating?
The bond rating entities set their own processes. We've been really consistent over a number of years of how we've targeted our reserve levels, and we have not had a downgrade. I don't know all the analysis that they would go through, but it could put us at risk if we fall significantly below our
Well,
targeted.
That's my point, Jeff.
Yeah.
It was not that big, and I don't know if you don't know that, but it's fine. I just was curious. Number two, you were bringing all these specialists in, which can theoretically generate income, yet you budgeted $3 million of revenue, and that's it from patient revenue. Is there any way to I mean, is that a realistic calculation, do you think? Or these are a lot of high-dollar patients?
They are, most of our patients aren't third-party patient revenue generators. We provide cost of services internally. It does help, though, with the recent approval of our Medicaid application, and we'll be looking to, over time, it's gonna take a while to ramp those services up, but as we ramp that service line up and that payer source, we would expect to see third-party revenue increase over the next couple of years.
Okay. If there's any way you could get me some information about, we're gonna be potentially borrowing quite a bit of money in the next few years, and the effect on the bond rate, if we could get some better idea as to what that difference would be, that would cost us a ton of money. So, thank you.
Thank you, Dr. Martin. Vice Chair May?
I confess I did not review my materials before the meeting, so I'm gonna have to go back and read all this stuff and try to figure out what's what. But more importantly, at least for now, I'm curious, are we going to be seeing Sendero's budget? I'm just asking a question.
Yes, it's on a little different cycle, and we can certainly have them come in and provide a financial update. Typically, they come in around October because they're on a calendar year, starting January 1. But if the board or the committee would like for Sendero to come do an update, we can certainly suggest that to the chair.
I'm not gonna request it, I'm just curious about that for now. And in light of the fact that we had just received CUC's budget, I was curious about them. So we'll figure that out.
Yes.
I would, I would like to have more information given the amount, you know, the increase. And I think it's predicated on a certain number of a new model. And so I would like to know
So
what
are you
we're
referring to
committing
Sendero?
Sendero.
Okay, so if we can have Sendero present at our next Budget and Finance Committee meeting. Thank you. Just for, just in terms of the order of tonight, I just wanted to let the board know, I personally requested that CUC present before Central Health because their budget impacts our budget. Just want to let you know the sequence why we've had it this way. Chair Rodriguez, do you have any questions?
I had one question and maybe a comment. One on attachment A, I was just curious, and you may have followed, you have answered this, but under attachment A, the reimbursement of funds from debt issuance that you said about 91 million, where did that get parked? Did it go to our reserves? Did it go to, where is it? Where did it go?
Good question, thank you for that. It is a little confusing. Initially, a few years ago, related to capital projects, we were planning on cash funding some projects, including Phase 2, Hancock, and Colony Park. When we prepared the budget for fiscal year 2026, for 2025, the timing wasn't there. We were budgeting for a $65 million cash infusion. That cash infusion was going to cash fund those projects. We subsequently issued debt, and so now we're reimbursing ourselves for that cash portion of those projects, plus another portion of the cash financing was related to the sale of some property. And so the plan all along was to debt finance those projects and then transfer the cash back from our capital project into our operational contingency reserve.
So that's where, the 91 is now in operational contingency reserves?
Yes, that's where it will be.
Okay, thank you.
Thank you.
And then just one quick other point, I really appreciate the handout around the proposed budget, especially, now did you, not only did you include the budget and the revenue, but you also included encounters by program, which I think is really helpful to the board around seeing the big picture of the volume. And I really appreciate, and I think looking forward around the transformation of our healthcare system to the payer mix. I think the one thing that I don't know if it's a question, but more challenge you all. I think maybe this may be more for Dr. Lee about not just budgeting, but what the goal might potentially be that the board would like to see. Because I see the commercial pay is like, it went up in FY '26 and went down in '27 from 9.2 to 8.6. It might be good, at least for the board, to see what you might have as a goal, as a stretch goal of saying, well, we want 10% commercial, because all of these payer mixes offset the tax burden and the affordability burden that's going on in our community. And so the more we can do sliding fee scale commercial self-pay, well, not self-pay, but commercial and sliding fee, the better relief you can give the taxpayers as well, especially on their value and return of investment. But thank you.
Thank you for the comment, and just what we're trying to balance is exactly what you said, but also meeting the needs of our patients also. So it's a tricky balance, but thank you for the comments.
Thank you. Just one thing before I forget. You have in your budget for AI and IT, like 5 million plus. I believe as a governing body, that AI policy should come to us, and we have not discussed it. And for you to include it in that budget before our engagement, I think you just went a step ahead. So just wanted to point out that to you, Chair.
Yeah.
Something that needs to come back to us. Thank you. Manager Valdez?
Yeah, just follow up to what Jeronimo asked, and that was, you said that there had also been a sale of property. If you could tell us what property has been sold, because that's going to go to, as we develop our capital project, our real estate and what buildings we own, property that we own. You know, it would just.
So these have already occurred, so it was the David, so it's.
So if you can just let us know, put it in writing, so that we can have that information. And so when it's alluded to here, or when you allude to it, it says in parentheses, this is what it was. And I just want to make sure you're going to send us the edits, the additional information, and instead of waiting till August the 6th packet, I mean the 12th packet to see the updated numbers, if you can send them to us as soon as they are updated.
Which numbers are you referring to?
Well, he was telling us that there was already going to be some.
So we had a couple things, some of the detailed talking points
That's
around
right.
the healthcare services. And then we had one error that we corrected
right, that's
around
corrected.
the foundation. So we'll net that back up and we'll send that out, just
So
so
we'll-
we can show.
So we can have an actual
And we'll-
corrected,
And we'll
current.
highlight where that change was.
Right, I appreciate
Okay,
that.
that should be an easy fix.
Yeah.
Yeah, thank you. Dr. Brinson?
If this is something you would prefer to do just with me individually or with me and Joe, I kind of would like a lot more detail on your prediction for the medical specialties. And when you talk about bringing the specialties online, I'd like to know individual specialties, how much you're projecting that they're going to cost, and how much you're projecting that they're going to be bringing in, so that we can get kind of a comparative view, kind of a thing for each specialty.
I think that's a really valid thing. I think that's something the whole board will be interested in,
Right.
something that we mentioned in attachment B related to that. And I think perhaps something that he can provide to the whole, and you can bring in your expertise and weigh in that comment.
Yeah, coming from a clinician, we'll get our clinical team involved in
thank
some of
you.
that. Thank you.
Okay, is that it? Dr. Lee, quickly? Yeah, okay. Just wanted to
So
conclude
just two
this
quick
meeting.
points, most of which we'll get back to you as we respond to all the questions. But regarding the AI point, I think that is something we are teeing up shortly. We just need to know which meeting with the chair and vice chair to bring it back to. But we know that that's something to do, and we're at a really good place. Excited for that discussion with the board. And then I just want to add 2 quick points in attachment B. The first point is that when you see the balance between network healthcare services and direct healthcare services, 117.5 million of the network healthcare services in primary care is community care. And so while it looks like roughly 2/3 of our budget is network, I would advise to think about 2/3 of our budget as direct, if we think about community care as really, our collective effort. So just wanted to point that out. Whether for accounting purposes we can flip that or not, I just wanted to make sure to state I think it's a significant point here. The other one I want to point out is that when you look at the list of services in that stack of direct service investment, I want to call out 3 in particular. They're toward the bottom of the list. You have transitions of care, 13.9 million. This is all the things that keep you from falling through the cracks when you go from the hospital to the skilled nursing facility and so on. A lot of the mischief and harm occurs without these services. Medical respite, 11.3 million. So folks who have no place to rest, recover, heal after the hospital, and then are going to end up back in the hospital or in the jail, on the street. Patient navigation, $9 million. So these collectively are $34 million of our budget. And I could go further and parse out mental health and so on, but these are areas where we don't bring in a lot of revenue from commercial payers. But I believe we add a tremendous amount of value to the public taxpayers because we reduce homelessness, incarceration, police utilization, ED, and hospitalization. And it's sort of the point of Central Health. You won't see that proportion of spend in the stack in a private health system, I believe. It's only in a public taxpayer-funded health system like ours that you see the deep investment in the places where the care journey breaks and the most vulnerable are hurt. So I just wanted to call out, we could trim those areas, but I don't think that's necessarily what the board would want us to do, although of course we'll follow the direction of the board. But I want to call those out. These are unusual, and I want to just name those three in particular in the stack.
Well, thank you for that. I would like to know the actuals, because I definitely know and the value of patient navigation to for patients, especially to connect them to care. That to me, I don't know what was the actuals for that, and also I don't understand the difference. So this is something we can take at a different conversation. The transition of care and the patient navigation, how you differentiate those two. I'm just trying to understand the differences between them and how you came to that amount. But I definitely understand the value, and I think it is essential for our patients, especially our most vulnerable ones here. Well, at this moment, I am going to adjourn the meeting.
A very quick follow-up to that one.
Yes, quickly, because I need to adjourn.
It's going to be very quick. It's just going to be with respect to those two specific transitions of care and patient navigation, the FTEs that are associated and the titles, to see if there's actually a difference in the job responsibilities.
Okay. Yeah. That.
I'm sorry.
Dr. Quickly.
Just one quick comment. I think that about what Dr. Brents and I were commenting about, as we work with CUC, we're going to stop hemorrhaging money, paying for specialists, and actually recover money if we have this closed loop system.
Yes.
And I think that the budget that they're proposing is actually less than we'll actually recover in terms of expenses and what we'll actually get. So I think it's a very conservative assessment in my opinion. But thank you very much.
Thank you. Okay, thank you, members. We will continue this conversation. Yes?
I would be remiss if I didn't recognize Katie from Pat's team, and Drew and Anissa from the strategy team. We would not have been able to pull this off without them. They really helped us with
Thank you.
the 30-page memo and this presentation, so thank you very much.
Thank you for that recognition. And on that happy note, I am going to adjourn us. Managers, we're moving on to agenda number 4. The next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, August 26, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this moment, I am ready for an adjournment. So Dr. Brunson's seconds, you move. I made the motion, you second. I'm losing it. So at the, all in favor?
Aye.
Meeting adjourned. Thank you.
Good evening. Today is July 29, 2026, and it is 6:23 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. As a reminder, some of our board members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. So we're gonna proceed to public communication, and just for the benefit of the public, I'm gonna call that to order to make it more accessible to community members, and we're gonna hold the public communication for the Board of Managers meeting. We previously had public communication for the Budget and Finance Committee, and I want to invite anyone that's here to make any public comments, if they would raise their hand. And I don't see anyone here that's for public comment, so I just want to make sure that we ask for that. And I'm gonna move us to the consent agenda. And I'm just gonna recognize that Manager Jefferson is gonna pull item C2 for a separate vote.
Thank you.
So I'm gonna, I need a motion from the board to approve consent agenda items C1 and C3. Manager Valadez.
I move that we approve on the consent agenda items C1 and C3.
Is there a second? Oh, I'm sorry, you have to do that with the mic on.
I move that the Central Health Board of Managers approve C1 and C3 on the consent agenda.
Is there a second? Manager, Dr. Martin, seconds. So having a motion and a second to approve consent agenda items C1 and C3, all those in favor, please raise your right hand. The motion passes unanimously. Members, I'm now gonna go to the one item that was pulled. It's the item C, I need a motion for approval of item C2, receive and ratify Central Health investments for June 2026. Is there a motion?
I go ahead and move that we approve item number C2 off the consent agenda. You need a second, and then
And
we
a
can go into
second, is there a
discussion.
second?
I second.
Dr. Brinson, Manager Brinson, I'm getting confused about manager, director.
Dr. Manager, Doctor.
Brinson seconds. So we have a motion to approve item C2, receive and ratify Central Health investments for June 26. All those in favor, please raise your hand. All those against? All those abstaining? So the motion passes 1, 2, 3, 4, 5.
I have a question.
Yes.
At what point in time are we gonna have discussion? I thought we were
Oh, I'm
gonna have
sorry.
discussion before
Yeah.
we actually took a vote.
Yeah.
You
So-
have a first and a second, you have discussion, then
Yes,
you have
I'm
the
sorry
vote.
about that. I made an assumption and I apologize. So the assumption here is that we have one board member that, any board member can pull a consent agenda item off. And the reason is that the consent agenda is usually a one where everyone votes unanimously. And so because there is a particular board member that has said that they're gonna abstain from this particular item going forward, actually, we should have changed the consent agenda item to just have that item pulled all the time so we can vote. So in terms of discussion, I don't know, Manager Jefferson, if you want to say anything, but for discussion
Nothing
purposes,
new.
I kind of knew what was going on. What's that?
I have nothing new. I've already communicated my
Yeah.
reason.
And that's why, because
Okay.
we needed a separate vote. But if there's any other discussion, please let me know.
The only reason I ask is because I was wanting for the public, because this is a public meeting, for the public's perspective, for them to understand what the concerns were.
Sure. I would like, I've asked that the investment policy be brought to the board so that we can discuss some changes, specifically in terms of the policy has the board approving the investments, the investment decisions, and so the consent agenda item would have had us ratifying it, which is approving it, and that's not my understanding of how governing boards of this nature normally handle public investments. So I would rather receive information. I'd be happy to receive the information, approve the receipt of it, but not actually the investment decisions.
Thank you, Manager Jefferson. Any other comments, questions, issues, discussion? Okay, I'm gonna close discussion. And there's been a motion and a second to approve item C2. All those in favor, raise your hand again. Sorry. 1, 2, 3, 4, 5. All those against it?
Abstaining?
And then abstaining. So 2 abstentions, 3 abstentions, okay. So the motion passes 5 yes, 0 no's, and 3 abstentions.
Wait, 5 yeses?
Yeah, 1, 2, 3, 4, 5, 6, 7, 8, yes. We're now gonna proceed to the regular agenda, members, and the first one is to receive and discuss a report from the board chair. I actually have 2 items. I think one of them is, I apologize for a second here. Where is, oh. One of them is to look for an email by the end of this week with a flyer for the August 31st community conversation with County Judge Andy Brown from 11 to 1 p.m. at the ACC Highland campus. And staff would like to encourage you to invite at least 10 people by sharing the flyer that we're passing along to you all. Oh, I need to keep one. And then the second is that staff has circulated a paper form to check availability for upcoming events over the next few months. So if you would just share your availability. And then the third thing I wanted to share was 2 parts to it. One, I just wanted to thank Elisa May publicly as the chair of the Strategic Planning Committee for her leadership around the retreat, the board retreat that we had Saturday, July 18th. And then I wanted to also open it up to board members around any feedback they, or any thoughts they have about the retreat itself. If they want to share anything, I'd welcome some thoughts from you all about it. Yes, ma'am. Manager Allen.
This is not with respect to Elisa, who did a great job. This is with respect to the invitation to the public and to the community to participate in the sharing of their concerns to us as we get ready to vote on a budget. Is this already on the computer? Is this already on our webpage? Where is this? We're getting this, a hard copy of this, but I was wondering if there's something that we could share through our different networks, you know, just by share.
The information is on our website in both Spanish and English, and you will be receiving the flyer by the end of the week electronically in both Spanish and English.
Okay, and you'll have a button down there that says just share.
Well, we can look into that for sure.
Well, just do that. Thank you.
Manager, we say.
Well, it's 2 questions. One related to this. I'm just curious about the timing, because a lot of, like, if you're seeking community input and people work during this time, how are you gonna be able to seek that? So I don't know who, that 10:30 a.m. to 1 p.m., who can attend this, especially for our population who are unable, because I think that is a barrier for them to leave work, especially for those who do work. It's just, I don't think it's a convenient time for majority of our population. So that's just a comment, and I don't know if it's a Central Health who set this time, whoever did, it's just a comment related to it. And I assume this is late right now, we cannot change, but for future reference, I think we should be
We will take that into
mindful.
account. Can I respond to just?
Yes.
The first 4 community conversations took place in the evening throughout the county. This one will be live streamed, and we will make sure that we share the information with community members as well. In previous years, this community conversation has taken place during lunch. We have seen that it's well attended, but we will take that into account for future years. So thank you for your feedback.
Well, thank you, Vaughn, appreciate it. The second part to my question, I could not attend the retreat. I was actually out of the country. So, and I read the memo, so I would probably touch base with the vice chair, whoever wants to share some updates, just to keep me updated. Based on the report that I read, it seemed it went very well, and I look forward to hearing more about it. Thank you.
Thank you. I wasn't able to attend either, and the memo was very detailed.
Okay, yeah, the memo was.
Manager Vela?
Just very quickly, the only reason that I'm 100% in support of a possibility of a time change for this last Your Voice community conversation is because the projected budget is going to be public. People will have an opportunity to be able to provide us their input at the community conversation also. And if nobody's thinking about that, then I would suggest that they go ahead and do that so that we have at least what appears to be another opportunity for public comment on our budget prior to going to Commissioners Court.
Thank you. I think we'll also have a public budget hearing as well, for the budget as well, yeah. Anyone else have any comments or thoughts as we, Manager Kitchen?
I felt like it was helpful because we clarified the timeline and the process, and I think we got on the same page for that, so that was really important. And we had the opportunity to discuss how we wanted additional input, and we wanted to include CUC board and Sendero's board, so we talked through how we would do that, so that was good.
Thank you.
And that would be for our next retreat.
Yeah, yeah.
Managers, any other thoughts? Manager Jefferson?
This session, we were working as a team with some members of the executive team, and that was nice doing that. But I also want to echo what Manager Kitchen said. We got clarity on the timeline and included a component where there would be some visibility to the public and opportunity for the public to participate, to have input as well in the strategic planning process. I think we made some good decisions about what the structure and the format would be. I do want to circle back because I feel badly, the budget presentations, the proposed budget presentations were really good. And I just want to thank, and the Central Health one I thought was just really well laid out. I will have some questions because, good presentations always generate questions. So I will have that, but I just wanted to make sure that I acknowledge that.
Yeah, thank you. Managers, anything else? I'd also add to what you said, Manager Jefferson. I think I really appreciate the hard work that you all did, especially around the no new revenue or new tax rate, because I think it's important for the board under their stewardship and obligation to just understand what that is and then kind of moving from there. And then I really appreciate the board, the retreat and the time that you all put into it. I unfortunately had a family commitment in South Texas. I couldn't be there, but I really trust the board and the will of the board. And then I think for us as individual board members, at least for myself, is to catch up with you all. And I have that responsibility, and I think we're all gonna have conversations with Karma to make sure that we're all on the same page and moving forward so that we're all kind of together speaking as one voice in the will of the board. So I really appreciate all the time that you all put in there. Yeah. I'm gonna move us to the next item unless there's any other. I announced that the board is convening in closed session to discuss agenda item 2 under Texas Government Code 551.071, consultation with attorney, Texas Government Code 551.072, deliberation regarding real property, and Texas Government Code 551.085, governing board of certain providers of healthcare services. Agenda items 3, 4, and 5 under Texas Government Code 551.071, consultation with attorney, and agenda item 6 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.074, personnel matters. And those items are item 2, review and take appropriate action on a potential lease of real property and other possible avenues to support direct mental health care and associated partnerships. Item number 3, receive and discuss an overview of regulatory issues impacting the central health system. Item number 4, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Dr. Patrick Lee, cause number D1GN 17005824 in the 345th District Court of Travis County, and services provided by faculty and residents of the University of Texas at Austin Dell Medical School in support of Central Health's mission. Item number 5, receive a briefing and take appropriate action on issues related to Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family, cause number D1GN 2300398. And item 6, deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. And the time is now 6:39 PM on July 29, 2026. Thank you.
share some of that joy with all of you. Like I get to hear about those stories. It's amazing to me that we're a healthcare organization and we get to do work like this. And so I know you all are getting here.
Recording in progress.
It really matters. It means a lot.
Why were we given this?
It's just
I mean, it's, I know it's his point of view, but.
Yeah, I guess it's just what I don't want to kind of.
Just, because Sydney mentioned it in her presentation, so I wanted you
Okay, to
all to be
understand.
aware that,
Okay.
that the mayor asked us to provide
Okay.
any comments he could pass along in his letter, so
Good. Well, I'm glad to hear he's all for this.
he had a very comprehensive letter.
Thanks to you. Or your team.
It's a collaboration.
Hasib is just now eating? You're just now eating, Hasib?
They're the open ones, so I just took the second one.
Oh, okay.
Good evening. It is July 29th, 2026, and the time is now 8:57, and we're entering open session. The next item on the agenda is item 7, confirming the next regular board meeting date, time, and location. And managers, our next regular Board of Managers meeting is tentatively scheduled for Wednesday, August 26, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I'm ready to accept the motion for adjournment.
So moved.
So moved.
Second,
Second.
Dr. Martin made a motion to adjourn, and Manager May made a second. All those in favor, please raise your hand.
We finished it.
The motion passes unanimously, and the time is now 8:58 p.m. Thank you.
No. I went to go to LA and then drove up the Pacific Coast Highway and seeing friends. I saw Julia move to LA, so spent a few days with her and then drove up all the way to Portland, seeing friends the whole way.